Thank you to the chairs. Welcome to the afternoon session. I'm delighted to lead out the speakers this afternoon. I would firstly warmly acknowledge the help, support and guidance of my co-investigators, of which this study has been greatly enhanced. So respiratory dysfunction. It is a clinical risk and it is linked to increased unexpected death, cardiac arrest and even admission to the intensive care unit. Oxygen therapy in itself is one of the major interventions used to manage respiratory dysfunction. In the clinical setting, it is the nurse that plays often the vital and at the forefront role of managing oxygen therapy, and especially managing oxygen therapy for those at risk of respiratory dysfunction. There are two key clinical indicators of respiratory dysfunction that we are able to use in our daily practice. These are the oxygen saturation and the respiratory rate. For both of these indications, there is a normal value, a normal threshold that we have. Going too low is problematic, and likewise having too much can also be problematic. So we need to be, as nurses and as clinicians, aware and diligent in our clinical duties to recognise and respond when oxygen administration is either too low or too much. Oxygen therapy in the clinical setting is common. It's actually very common. We use it to either treat or prevent hypoxemia. It is routine in our practice, and often we do it as part of habit. We feel that we're doing something beneficial when we apply oxygen to our patients. We titrate oxygen. We can get an effect and we can have an outcome. However, oxygen therapy in clinical practice is multifactorial. There are a number of things that we need to do to consider and evaluate when we apply oxygen therapy to our patients. Key characteristics or factors that implement or affect the ability of oxygen therapy to be effective are the device characteristics, the patient themselves, how do we as nurses know and learn and use oxygen therapy, and in what clinical context are we using oxygen therapy. Oxygen therapy decisions, therefore, are complex. There is a range of things that we need to do, we need to consider when evaluating the need for, use of, or discontinuation of oxygen therapy in clinical practice. A key step, really, the first step, is to identify that there is a need for it. There is a cause or something that we can do to treat it. Second step would often be, what are we trying to achieve? What oxygen saturation do we need to achieve? Following this, we actually need to choose something to give oxygen with. There are a range of oxygen delivery devices that we can use. Nasal prongs, face mask, as we'll hear later, high flow nasal oxygen therapy. We need to make sure that the devices that we're using are fit for purpose. A, they're going to achieve the goal, but also going to be tolerated by the patient who needs to wear it. And similarly, we need to evaluate its effectiveness. So the aim of this research that I did, the background really, is that the evidence suggests that the choice of device, nurse characteristics, patient and clinical factors, both individually and collectively, impact the effectiveness of oxygen therapy. However, it is the variation in the management of oxygen therapy that may compromise patient safety. So really the question that we need to ask is, are we managing oxygen therapy effectively or mismanaging oxygen therapy because we could be achieving better outcomes? The aim of the research that was conducted was to provide a detailed analysis of nurses' management of oxygen therapy for patients at risk of respiratory dysfunction. We had three key objectives. Our first objective was to actually evaluate the clinical efficacy and user-friendliness of three devices. These devices were the nasal prongs, face mask, and nasopharyngeal oxygen catheter in adult patients. Secondly, we wanted to understand the patient and nurse experience, perception of, oxygen therapy. And thirdly, and importantly, we wanted to evaluate how intensive care nurses were documenting their management of oxygen therapy in clinical practice for patients at risk of respiratory dysfunction. Yes, it's a bit complex, so the methods needed to be equally complex, but not burdensome. It involved a randomised controlled trial to evaluate the clinical effectiveness of nasal prongs, face mask, and nasopharyngeal catheter. We conducted patient and nurse interviews to understand their perceptions of oxygen therapy. We also performed a retrospective medical record audit to understand how oxygen therapy was being documented in clinical care. And importantly, we also observed clinical care to understand the contextual factors associated with oxygen therapy management. The 4 studies were conducted in 2 metropolitan hospitals here in Melbourne. Patients were those aged 18 or more receiving oxygen therapy and had SpO2, so oxygen saturation monitoring, and also respiratory rate monitoring. The nurses that were participants were those who were caring for the patients or those that we approached for the interviews. Ethical approval was obtained prospectively before any data collection or the studies were conducted. So what did we find? Essentially, to distill this work down, it came to 4 main themes. There is factors that we need to consider related to device selection. There are considerations related to patient comfort and their compliance with oxygen therapy. We also found things that were associated with the monitoring of oxygen therapy effectiveness, and also we looked at the documentation of respiratory care. With regard to device selection and the randomised crossover trial that we conducted for our patients, we can see that for oxygenation, all 3 devices were equally effective at maintaining an oxygen saturation of 97 or above. To do this, as you would expect, or you might hypothesise, the nasal devices delivered oxygen at a lower flow than face mask. And when asked, the patients told us on a scale of 0 being most uncomfortable to 100 being most comfortable, that yes, they preferred the nasal devices overall. One could take away from this that in the event of using a face mask, one should also consider using nasal prongs because of the lower flow delivery, increased patient comfort. When asked to look at the patient comfort and compliance, nurses typically targeted an oxygen saturation of 95 and above, and they often tried to use a face mask because they sometimes found that the nasal prongs were just uncomfortable or fell off. Conversely, patients would tell us that the face mask is actually miserable. It makes them feel miserable, it's hot, it's sticky, and it actually makes a shocking noise. And for some people, they can't see past the nasal prongs. So essentially, the nurse perspective of oxygen therapy was to drive therapeutic effect. There was issues associated with compliance because they wanted to keep it on. Nurses would educate and provide reassurance about oxygen therapy, but often their choice of oxygen delivery was associated with their familiarity with the device. Patients, however, they really sought patient comfort. They wanted something that was going to be comfortable, that allowed them to perform their own activities and was effective. So in a nutshell, nurses seek therapeutic effect, whereas patients seek comfort. The monitoring of oxygen and oxygen therapy was oxygen saturation and respiratory rate dominant, but nurses didn't always respond appropriately to signs of hypoxemia or tachypnea. They didn't always increase the flow rate or even change devices to keep oxygen going. We did look at the medical documentation of what was documented versus what they were doing, and nurses tended to, when looking at oxygen delivery, document a higher oxygen saturation than observed, and also they documented fewer hypoxemic episodes than observed. Conversely, for respiratory rate, nurses would document a lower respiratory rate than observed and would also document fewer tachypnea episodes than observed. And we could try to understand why. However, in the presence of time, these 4 linked studies illustrate the interplay and complexity of oxygen therapy management for our patients. And the interplay itself begins and continues on with device selection, but must contain issues of comfort and compliance. We need to optimise patient comfort and compliance in order to get to be clinically effective. It's not a standalone issue. We need to consider these issues in combination and be mindful of our own clinical context. So the clinical implications of our study was that there is an urgent need to critically appraise our oxygen therapy practices. We need to develop evidence-based guidelines that are multidisciplinary and patient-centred. However, we are not silly and we recognise that changing clinical practice will most likely combine prospective trials, educational strategies, the use of local champions, and obviously decision support tools or reminders. So from here, we hope to identify further decision-making processes that will aid the quality improvement initiatives associated with oxygen delivery, develop and integrate clinical practice guidelines, and also to improve our methods of monitoring and documenting vital signs, in particular respiratory rate and oxygen saturation into critical care settings. In summary, clinicians need to review the way they select and manage and monitor oxygen delivery for their patients. Clinicians also need to document appropriately the care that is provided and delivered, in particular for respiratory rate. The findings of our study can now inform future interventions to improve oxygen delivery aimed at managing and optimising patient safety and outcomes. Thank you very much.